Good morning, and thank you for inviting me to speak at this event. It's quite an honor. When Eli asked me to be the keynote, at first I declined. I really didn't feel I was qualified to speak to health policy in Washington State because I've only been back a short time. I started my position as the administrative officer in December of 2023. But here I am, and I hope you find what I have to say thought-provoking. I didn't practice with this thing. Hopefully. Yay. Okay, so this is our agenda for today's presentation. And so first, I always like for my audiences to know a little bit about me as a person before I dive into the material. My journey to becoming who I am today started when I found myself a single mom with 3 little ones. This picture was taken when we were on our way to Spokane from Mississippi to live with my parents. My life had been turned upside down, and I knew I needed to figure out how to take care of these 3 precious souls. At this point in my life, I was barely a high school graduate. I graduated from Lewis and Clark with a 2.1 GPA, and that's by the skin of my teeth. I'd taken a few courses at community college. I had gone through Air Force basic training and technical school and had been a stay-at-home wife and mom. How was I ever going to be able to provide for my children? Well, I chose to go back to school. I graduated from Whitworth and went straight into the social work program at EWU. Eventually, I achieved my final degree at the University of Arizona with a doctorate in public health policy and management. And I'm really glad that it was mentioned that oral health is one of my passions. They thought I had Hodgkin's disease when I was 9 years old, and they gave me radiation on my neck. And back then, they really didn't understand the connection between saliva and poor oral health. And doctors probably talked to dentists even less back then. And so by the time I was 11 years old, I had rampant caries. And so that's because they killed my saliva glands. So consequently, I always have to drink water. Anyway, that's a side note. It's not in my script. Okay, so what does SRHD do? Well, I hear from a lot of people that they have no idea what goes on in that funny-looking building next to the courthouse. I also hear, what is SRHD? I respond and say, well, it's the Spokane Regional Health District. And the response is almost always, oh, you mean the health department? And the answer is yes and no, because we are the local health jurisdiction for Spokane County, but we are not a department of Spokane County. We are a special purpose district. We are a municipal corporation with fiscal and administrative independence from the cities and the county. And little things like that are important to me because they're nuances that are important and truly affect how we do public health in Spokane County. So there are 3 core functions of public health. They are assessment, policy development, and assurance. And you can see these on the outer edge of this graphic. The graphic is outlining the 10 essential services of public health. The 10 essentials are based on the National Public Health Standards, which provide us additional guidance on how we are expected to actually do our work in each of these categories. At SRHD, we provide all of the services shown on this wheel. But what I really want to point out here is the center. At the center is equity. In my current role at the health department, see, even I do it, I am helping our organization to move forward in working through an equity lens. Equity should be at the forefront of our minds in all that we do to ensure that we are not perpetuating or contributing to inequities in our communities. At SRHD, we receive ongoing training in an effort to develop cultural maturity and a deep understanding of how we as individuals can help address health inequities in our communities. I'm happy to acknowledge that some of our health equity program team are here today, right up there. And one of the exercises that the team does with our employees is this wheel of privilege. And I didn't know how many people were attending today, so I apologize. I only brought 40 copies of the wheel of privilege, and it is on your table. There should be at least one copy on every table. And the instructions for how to use this wheel are really simple. You just circle each of the words on the wheel that apply to you. And this is a really simple tool that helps us to see our privilege or lack thereof. It has the potential of helping us as individuals to identify potential blind spots we may have. Our team, and I wanted to mention one of the main reasons I brought that was it really is a very simple tool that you can have your employees and your staff do so that they themselves can have a better sense of their own privilege. And I'll talk a little bit more about equity later. Our team works with community partners to identify barriers and with our internal programs to help modify our programs to address the equity issues the team identifies. And we have a table out in the foyer, and there is an equity report that was just recently published, and it really goes into detail about how does our equity program do this and be so effective in helping our programs to look and do their work through an equity lens. So at this point, you might be saying to yourself, when is she actually going to tell us what SRHD does that is relevant to behavioral health? And so this is a high-level programmatic organizational chart of SRHD. We have 5 divisions, 5 primary divisions, and I believe that all 5 have some relationship to your family, your clients, and you. And now if you are not from Spokane County, you also have a local health jurisdiction that does many of the same things that we do, because we meaning all local health jurisdictions in Washington State, follow the 10 essential services of public health. So let's take a closer look at each one. How many of you have used the Community Health Needs Assessment data or Quality of Life Survey data to help you write grants? Can I see a show of hands? Yeah, quite a few of you. And our data center has an amazing team of research scientists who have developed dashboards and data for our community members. And you can find them simply by going to www.srhd.org. And at the very top, it says Data and Reports. And you can click on that tab. And the cool thing about our data center is that if you have a unique special need for data, you can call them and you can talk to them about your unique need. And we often are able to work with your organization to help you to collect the data that you need to collect, or find the data you need if it is secondary data. I believe that every program in our community health division intersects with behavioral health, whether it's the child death or overdose fatality review boards, or our nurse family partnership that is a best practice intervention with high-risk pregnant women. The outcomes are, it's solid, it's the David Olds model, and the data shows a stark decrease in adverse outcomes for the children that are born when they have participated in this program. And so we actively work with organizations throughout the community. If they have an individual who comes in who's pregnant and is high risk, we take referrals from everywhere, anywhere. Anyone that identifies a pregnant woman who is less than 28 weeks pregnant and high risk, we will work to bring that person into the program. Okay, so even environmental health, that program touches not only your clients, but also each of you in the room. We inspect schools and playgrounds to ensure they meet safety standards. We inspect food establishments to ensure you don't get sick when you go out to eat. And we inspect pools, spas, water features at the hotel that you might be staying in during this conference. We make sure they are safe to swim, soak, and play in. You can see what is coming next, and that is our finance division. And you might be wondering, what's she going to pull out of her hat here? How can finance impact us? Well, our finance division includes vital records. And one of the services that we provide our community, and if you look back over to the disease prevention and response column, you'll see the homeless outreach circled there. We help our community members who are living outside to get ID cards so that they are able to enroll in Medicaid and other programs that require identification. We couldn't do that without being able to access their birth certificate. And so we work closely with our community members living outside to help them to get their ID cards. Treatment Services is an opioid treatment program. We've been in the news a lot lately but I'm not going to go into any of that. We offer low barrier services to individuals in our community who are working to live a successful life while also working to address their opioid and our fentanyl addiction. We have mental health treatment providers within treatment services, and we have substance use disorder professionals who provide counseling services to our clients. We serve approximately 1,000 clients every week. And I believe one of the opportunities here for perhaps some policy consideration is that an individual who is addicted to opioids and fentanyl, if they are on methadone, that methadone to them is just like insulin to someone with diabetes. It's like an inhaler to someone who has asthma. The brain forever alters, our addiction to opioids and fentanyl forever alters the brain. And by using methadone, and 95% of our clients are on methadone, they are able to navigate life successfully by having that methadone. It helps them to live life successfully once they've made it through all of the counseling and everything to help them on how to live in our world. And I am going to say a little bit more about that a bit later. But we also do things in treatment services, like collaborating with the Community Health Division to hold a baby shower for any and all pregnant women who have a newborn under the age of 6 months, not 6 months. Did anyone in the room from an agency receive a flyer about the community baby shower? Nope. Okay. Well, I know Frontier Behavioral Health did, and a bunch of others. It's tomorrow from 10:30 a.m. to 1:30 p.m., and it's at the main health department, that building, again, 1101 West College. And anyone, again, it's available to any woman who's pregnant and or has baby under 6 months. In the Human Resources Division, we work with our colleges to offer opportunities for real-life experience as a field placement site. We regularly have more than a dozen students working on projects, completing their practicums, or internships at any given time. Our public information, and those are your future employees, just so you like, and I think every single one of our students that come through have expressed just how much they learn through our programs. And of course, we connect them appropriately, like nurses to the TB program or nurses to the Nurse Family Partnership, etc. So our Public Information and Governmental Affairs Division houses the Equity Team and is responsible for the weekly Facebook Live that Dr. Velasquez hosts every Wednesday at 9:30 a.m. Dr. Velasquez covers a multitude of topics with both invited guests and employees to help our community understand the role of public health and the importance of collaborating across sectors. Lastly, our administrative division helps to make sure that all we do keeps running smoothly. So what have I learned in 2024 that's relevant? And in April of this year, I attended the Washington State Association of Local Health Officials Leadership Retreat. And there I was introduced to the Surgeon General's report on workplace mental health and well-being. These are some sobering statistics that were shared in the report. The last one is the one that concerns me the most. Well, all of them concern me. But the last one, 81% of workers reported that they will be looking for workplaces that support mental health in the future. The Surgeon General and his team developed a framework to address workplace mental health and well-being. And when I look at this framework, I say to myself, yes, this is what I want too. I want to work in an organization that cares about me in this way. Absolutely. And again, what do you see at the center of this framework? Worker voice and equity. How can I make this vision a reality at SRHD? That's my current passion. And how can I help other leaders, do the same? A giant step forward was just published this month. And it's a new instrument that was designed to measure those 5 dimensions of the Surgeon General's framework, and it is called the Augustus Scale. Okay, and I know that this slide breaks all the rules for presentations, but my main reason for showing you is that the questions and this questionnaire is in the in the public domain and free for anyone to use in their own organization. So, ideas and innovations. I attended the Innovations in Psychotherapy conference earlier this month. I was pretty blown away with everything I heard and learned. The focus of the conference was on trauma-informed care. And there is a growing body of research that indicates the medical model of approaching mental health does not work. When we, in the behavioral health field, treat the symptoms of a diagnosis, we miss the pain that is driving the symptoms, the traumas that our clients have experienced in life. I foresee a shift occurring in our field away from the DSM-5 and one-size-fits-all interventions to a more compassionate approach that focuses on healing the pain that is driving the maladaptive behaviors. In California, they were able to pass legislation that pays for using the Adverse Child Events, or ACEs, assessment with all pediatric patients in the medical setting. Patients, these are children, that score a 4 or higher are then eligible to enroll in an intervention program that addresses with their parents the impact of the trauma the child is experiencing on their current and future well-being. The outcomes data so far of implementing ACEs in pediatric clinical settings indicates that California will save over $1.5 trillion by lowering the incidence of conditions associated with untreated high ACEs scores. I wish I had time to share everything from Dr. Nadine Burke Harris's presentation. It was fabulous and truly an innovative and preventive approach to behavioral health challenges for our youth. Again, her name is Dr. Nadine Burke Harris. She was the first Surgeon General for the state of California, I believe. And as I shared previously, my current passion is figuring out how leaders like myself can create a workplace where mental health and well-being are the top initiative and goal. And as I listened to the presenters at the Innovation in Psychotherapy Conference and heard about things like compassionate inquiry from Dr. Gabor Mate, and also his method of when the body says no, and all the others, I see a shift coming among employers to place where we understand that personnel issues are symptoms and are a direct result of unresolved trauma in the employees' lives. And also for those of us working in behavioral health, we have such an intense daily exposure to, of course, the word's going to fly out of my head. That's why I use script. Vicarious trauma. You know, it's trauma every day that we are just constantly being flooded with. And as I listened to Dr. Burke Harris, I couldn't help but wonder, wouldn't it be wonderful to have a similar program for our employees who have experienced trauma to help them overcome their own traumas? I believe eliciting commitment from leadership at all levels of our organization to make this a priority and goal for our organization is the first step. Then hearing from our employees, along with using the Augusta scale to measure the current mental health and well-being of our employees, is a good starting point. And we all must find the courage to change in this area, or we will continue to struggle to retain employees and have healthy workplaces. And so, with that, thank you for the opportunity to share about what SRHD does and share some ideas and interventions. Does anyone have any questions for me? And I believe we have a microphone back here. I'll take any questions. Doesn't have to be on the presentation.
Hi, thank you for your talk. Amy Osterman with Walla Walla County Department of Community Health. I'm wondering something for Spokane Regional Health District. Has knowing this information and the thoughts that you just shared change how you structure the work for your staff at the health department, your spaces, engaging with the community, anything like that?
Well, I can definitely tell you that the work of our equity program and the members of our equity team are definitely beginning to work with all employees and all programs to talk about equity. And if you are able to go to the Surgeon General's report and drill down on that sense of community and belonging, you'll see that diversity is a huge part of that. and helping our employees to understand how diverse we are in our workplaces and to be more accepting of people's differences, which are truly really minor in comparison to how much we are alike. And so, again, I've only been in my position for 10 months. And so, as you all know, change is scary and it doesn't happen quickly. And so I'm one of those leaders that just bit by bit by bit, I throw something out and I see if it's time for it to stick. But this one I will not let go, because I want our employees, all of our employees, to come to work and not be one of those statistics. And we have work to do. I think there's a lot of organizations that have work to do, because especially when it comes to our service organizations, we really focus on the people who we're serving, and we haven't really focused on the individuals who are providing those services. We have another question right here. Can you write? Okay.
Hi, thanks for your talk. What state policy do you find most helpful to the work you're doing right now, or would you like to see changed this session in the legislature?
Well, last night we had a really wonderful gathering of decision makers in the state. And one of the things that I heard multiple times was flexible funding. And Washington State passed this wonderful legislation called the Foundational Public Health Services. And public health now has flexible funding to use those funds in however we need to use them to help us address the issues in our county. And so as far as the work of public health, truly that was an amazing piece of legislation that, oh man, I wish I had had the same thing in Montana and Arizona, because, I'm not going to go down the path of like being a budget wonk, but in public health, and I'm sure other organizations are the same, but we have very extreme categorical funding streams. And we have like 93% of our budget is all categorical, which means this is how you can spend it. Right here. You can't go outside of that parameter. And so 7% of our budget, we have some discretion in how we can use it. So I don't know if that's specific, but I can say that what I'm learning, and I'm definitely not at the level of understanding that would make me feel really confident about talking about it here, but I know that there's this huge problem with opioid treatment programs being able to talk to other behavioral health systems. I think it's 42 CFR Part 2 that is like really, really intensely like the client information that we have is we can't share it. It has to be kept confidential. And that really puts up a barrier to our clients accessing additional mental health, behavioral health treatment throughout the community. Yes, another question back here. Did that ring true for anyone in the audience about 42 CFR Part 2? No?
I am a registered nurse in this community, and I'm wondering, based on your comments about methadone treatment, do you have any concerns about Spokane County's intent to privatize the methadone treatment center, especially given the revenue it generates for public health in our county?
I was expecting a question like this. So there's a nuance to what you just said. And what the nuance is what I believe you said was looking into privatizing. And what we're doing is a feasibility study to see if that's even possible. I have done a multitude of research, and I haven't found any public opioid treatment program that has been able to go and separate into a private organization. And one of the biggest challenges that we have, it would actually hurt SRHD, the organization, to lose treatment services, because you're exactly right. It does generate revenue. And it also contributes to our indirect cost allocation plan, which covers all of the administrative costs of running an organization. But the concern is that operating an opioid treatment program from within a governmental entity, we can't operate like a business. Even going back to the revenues that treatment services generates, what happens to those revenues at the end of the year? Those excess revenues get folded right back into the general fund of the health district. And that's 100% normal and the correct thing to do within a governmental organization. But for an opioid treatment program that desperately needs to expand their services, that inhibits their ability, because the expectation is that the program will have the funds, and this gets a little bit complicated, but it's the reality in government. When you are asking for new positions to be added, they say, show us that you have the money to be able to cover these costs. And at the same time, the excess revenues have been put into the general fund and are not accessible to treatment services. And so what the feasibility study is doing is acknowledging that the status quo cannot continue. It can't continue. We either have to make changes to how we are conducting our business of the opioid treatment program at SRHD, or we need to look at having someone from outside take it on. And the board has been clear that they, even if at the very last moment of an RFP process, they feel like there is not a single organization who wants to take on treatment services that is able to provide the same quality of care or higher care than we do, they will end it. And so my biggest concern about it is that just asking the question from the community, from the employees, from our clients, has caused considerable distress. But it's something that we need to do, because for years, I worked at SRHD. I started working for SRHD in 1999, and I left in 2007. Even back then, they were talking about, well, should we keep treatment services in public health? Because that's really not what public health does. We're not a healthcare provider, but opioid treatment program is basically a treatment provider, an individual healthcare treatment provider. And so, did that answer your questions? Do you have any further clarifications that you would like? Okay. Any other questions? Yes, sir.
Not a question. Just wanted to make a friendly amendment to your 42 Part 2 comment. You can exchange information. What it requires is a consent from the individual whose information you're seeking about. And some federal rule changes recently allowed expansions to that. So yes, you still have to get consent from the person. And the reason is that in some states, people wait outside the opiate treatment programs to arrest folks or to, take them to jail. So it's really meant to protect the privacy of folks, but you can exchange information between health providers, and there are some expansions to ways in which you can do that, and they're more HIPAA-like. So it is doable. It's a bit of a pain, arguably, for the staff, but it can be done.
So that might be an opportunity to look into and how we could streamline that process for staff so that their immediate knee-jerk reaction is, no, we can't share information. Yeah, thank you for that. I appreciate it. Do we have, okay, I think we have a hand up over here, and then we have a hand here. And how are we doing on time? What was that? On time? We're a little over. Oh, I have a 9:30 meeting. Oh, bye. It was nice talking to you. I have a committee meeting that I need to get to. So thank you all very much. I appreciate you.